Back again so soon, you're thinking? Well, in this session, I'd like to talk about our use of general anesthesia in cesarean section. This is sort of a high-level overview. I'm not going to tell you how to do general anesthesia or pitfalls, that sort of thing. I just want to talk about our practice in general and the way we think of general anesthesia. I have absolutely no financial disclosures regarding this topic, nothing to worry about. And I think to understand what our approach is to general anesthesia in the obstetric population, let's take a look at the population that we're serving in our obstetric practice in general. In this day and age, there's somewhere over 4 million births in the U.S. Every year. Our C-section rate is north of 30%. In 2009, it was 32%. And that means that in 2009 at any rate, we did 1.3 million cesarean sections. I'm sure we're still doing over 1 million every year today. So we're doing a whole lot of C-sections, but only about 52,000 of those C-sections in 2009, 52,000 out of that 1.3 million were done under general anesthesia. How can I say that, you might be asking yourself? Well, I admit I am extrapolating from the study by Buckland that was published back in 2005. So the question becomes, if we're doing that many C-sections and that few are done under general anesthesia, why are we using it so infrequently? What are we concerned about? Is it a difficult airway that we might run into? Is it the risk of aspiration in these patients? Perhaps there's an increased potential for hemorrhage if we use general anesthesia. All these things have been voiced as concerns in the literature. But in reality, our biggest concern is encountering a difficult airway. But why are we so concerned about this? Well, we must step back a little bit and take a look about how we got to where we are today. I think this was a legitimate issue 30 or 40 years ago. And while our population, their demographics, our practice of obstetric anesthesia, our practice models have changed, our approach to patients for general anesthesia for cesarean section has not changed. Today, in 2005, the risks to our patients have changed. What has changed, you might ask? Well, to understand that, again, we need to look back and see how we got to where we are today. So in 1980, there were roughly 3 million deliveries in this country, and the C-section rate at that time was only about 16.5%, so a lot lower than the C-section today. So that means there are just about 500,000 deliveries, or 500,000 C-sections done in the country in that year. How do we deal with all those C-sections? Well, we used a lot of general anesthesia. Charlie Gibbs published his landmark survey of obstetric anesthesia practice in the U.S. in 1986, though when I spoke to him, he noted that the study was actually performed in 1981. It just took that long to get it analyzed, reviewed, and published, and all those sort of things. So this is fairly concurrent with that 1980 data. What he found was that general anesthesia at that time was used in 41% of the cesarean deliveries in this country in facilities of all sizes. So we're doing fewer C-sections, but we're doing a whole lot more general anesthetics 30 or 40 years ago. 25% of those anesthetics were performed without an anesthesiologist being involved at all. You might say, well, that's okay, there's a nurse anesthetist. No, there weren't nurse anesthetists either. These were not anesthesia-trained personnel who were delivering these general anesthetics. In many instances, they were obstetricians, they were internists, they were God knows who, that really wasn't clear in the report, but these were not anesthesia-trained personnel. And less than 50% of facilities in the U.S. of all sizes had in-house coverage for obstetric anesthesia. So that means when there was a C-section to be done, and remember, we're doing fewer C-sections, a lot fewer elective ones, people are getting called in from home, so they're doing these procedures in an urgent mode. They're coming in, inducing general anesthesia. Obviously, this led to a different variety of problems than what we have today. So, 30, 40 years ago, we had a lot fewer C-sections, And we had fewer elective ones. We didn't have all the scheduled C-sections like we have in this day and age. There were more anesthetics performed in an urgent mode. We had less experienced providers, poorly trained providers. What sort of complication did this lead to? Well, I don't think you have to be a genius to figure this out. We've never been great at compiling our complications in this country from a global standpoint, but they do a pretty good job in the UK. And every 3 years, they analyze all the deliveries in the country and all the complications in a report. And if we look back at the confidential inquiries, which is called, into maternal deaths in England and Wales over time, you see that in the 64-66 epoch, there are 8.7 maternal deaths for every 100 maternal deaths in that country. Moving forward, by the time we got up to 1976-78, that number had swelled to 13.3 anesthesia deaths for every 100 maternal deaths in that country, or in that epoch. So the majority of deaths that was cited are from anesthesia associated with anesthesia for emergency cesarean delivery. What does that mean? General anesthesia. So, how do we address that problem, and what did that mean for the way that we were being trained and still are being trained today? Well, if general anesthesia is causing mothers to die, you really have two options. First, you can improve the way that you're providing general anesthesia. How do you do that? Well, improve airway management skills. Your options were pretty limited back in 1980. If you wanted to intubate a patient, you had basically, near as I can figure, I hate to say near as I can recall, three choices. You had direct laryngoscopy, you had blind techniques, nasal, oral, whatever, or you had fiber optic laryngoscopy. And this was not a simple process back in 1980. You had a large, bulky scope, you had connections you had to make. This is not something you would do in an urgent mode when you suddenly decided, wait a minute, I can't do a direct laryngoscopy on this patient. So we're going to improve our skills at airway management? Not very likely. The second option was a whole lot easier. Let's decrease the number of problem anesthetics. Let's stop doing general anesthesia in these patients. Moore, in his textbook, Obstetric Anesthesia and Analgesia, published in 1986, wrote, "It is evident that difficult or failed intubation account for the majority of maternal deaths associated with anesthesia, and that regional anesthesia rarely causes death." He went on to say there is only one certain way to avoid complications during general anesthesia, and that's the substitution of regional anesthesia. So don't do general anesthesia for C-sections. Pretty simple. And this became the basis of what we've been teaching and what we've been practicing ever since. This became a single theme, both sides of the Atlantic. Yes, the Brits were better at cataloging this and bringing this to our attention than we were in this country, but even in this country, there were publications that urged reduction in the use of general anesthesia. Lawrence Zen, sitting right up front here, in 1998, wrote a paper reviewing their experience with general anesthesia at the Brigham over a 7-year period. Quoting from that study, improvements in morbidity and mortality due to anesthesia may be achieved by further decreasing the number of general anesthetics. Even the obstetricians got on board with this concept. And they wrote in their committee opinion, Anesthesia for Emergency Deliveries, that they encouraged the greater use of regional anesthesia whenever possible. What was the result? Well, let's look back at Buckland's survey, which I briefly quoted earlier. She updated Charlie Gibbs' original anesthesia workforce survey in the early 2000s. What she found was two big changes in our practice, two big shifts. By 2005, the rate of general anesthesia for C-section was less than 5% in the US, and it was less than 3% in the largest facilities. And in all but the smallest facilities in the country, those with less than 500 deliveries per year, the rate of in-house coverage for labor and delivery had doubled over the previous 20 years. But Our workforce that's providing obstetric anesthesia has changed also. The services that we provide are being provided by a better trained professional, be he anesthesiologist or anesthetist. Anesthesiologists and anesthetists have all been trained in the subspecialty of obstetric anesthesia, which includes difficult airway management, including management of the difficult airway algorithm and these sorts of things. In-house coverage means better planning and preparation and, importantly, better communication. Difficult cases are likely to be identified early, so planning can occur, and you have fewer emergent interventions required. And finally, we're having fewer cesareans being anesthetized emergently because of these changes. So, the obstetric population, our training in obstetric anesthesia, our workforce have all changed over the last 25 years. Has our thinking about our cases and our patients kept pace with all these changes? And I would have to say, no, it hasn't. The challenges that we face nowadays in our practice have changed. If we look at the latest, or one of the more recent triennial reports from the UK confidential inquiries from 2011, there were only 7 deaths associated with anesthesia in the 2006-2008 period. That's about 3% of maternal deaths. And you recall, that's down from 13% in 1978. So the number of anesthesia contributory deaths in their series declined significantly. And there was only a single death in that series from failure to ventilate. Pardon me. McClure, writing in the British Journal, wrote that deaths from airway causes have decreased since the 1960s. Cynthia Wong from Chicago wrote an editorial that accompanied the report in the British Journal of Anesthesia, and she noted that the etiology of anesthesia deaths has changed over the last 2 to 3 decades. Specifically, in the 1980s and 90s, it was related to securing the airway. The case fatality ratio for general anesthesia versus regional anesthesia in obstetrics was 16.7, meaning you were 16 times more likely to die if you received a general anesthetic for your cesarean section back in 1980 than you were if you received a regional anesthetic. But by 2008, where we only had 1 death from failure to ventilate, the case fatality ratio for the 2 types of anesthesia was the same. There was no difference. So general anesthesia did not mean you were more likely to die than you were if you had a regional anesthetic. But looking here in the US, there is some data that can inform our practice, and regional anesthesia in the US is not without complications either. If we look at the closed claimed analysis published by Davies back in 2009, they reviewed obstetric anesthesia insurance claims from the 1990 to 2003 period, so about 14 years. What they found was there were maternal deaths and brain damage due to general anesthesia. There are 28 cases in their database. If we look at regional anesthesia, there are 41 cases of maternal death and brain damage in patients who received regional anesthetics. And a study stated that in 80% of the cases of high neuraxial block, there was a delay in recognizing and treating the sequela of the high block. So essentially, we've created a new problem with our avoidance of general anesthesia. Yentis, back in 2001, in an editorial, noted that high regional block may be the failed intubation of the new millennium. He said, as deaths from failed intubation decline, a new specter emerges, or rather, an old one resurfaces, high regional block. So knowing all this, we're still hesitant to use general anesthesia. Why is that? Well, what are we concerned about? Is it the risk of aspiration? Is it the increased potential for hemorrhage? No. We're still concerned about encountering a difficult airway. So let's see how rational that fear is. What is the incidence of difficult airway in obstetrics? Is this something to really be scared of, or is just the lingering specter of a long vanquished foe? So what is, or what does the term failed intubation mean? Anthony Rock over 20 years ago now, published a series of 1,500 general anesthetics for C-section, and he looked at the relative risk for difficult intubation. All these intubations were performed by residents, so these were not seasoned professionals. They were not the most experienced person in the room or in the facility. They were the trainees. What they noted was that the actual failed intubation rate was only 1 in 750. Okay, that's significant, I'll give you that. But if you read the article carefully, it says subsequent tube placement by the senior anesthesiologist was performed. So they didn't really fail at intubation, they just had to get somebody who was better at it to do the intubation. And even with Malampati 4 airways, which I would say is not really a great indicator of difficulty with intubation, but that's a whole other issue. There were no failed intubations, and only 5 of the 76 Malampati 4 cases in their series were even considered difficult. But what is our complication rate? The problem is that complication rates are very low in modern practice, and there have been some reviews, such as Tony Rock's there, but even the busiest practices take years to gather large databases. So at the risk of going to Dr. D'Angelo's head, I too am going to cite the SOAP SCORE project, which was a multi-center registry of serious complications of obstetric anesthesia. This was published in 2014 and is certainly the largest and most comprehensive prospective collection of our obstetric anesthesia practice that has been reported to date. This was 20 centers in the U.S., many contributors, again, from right in this very room. This included over 300,000 deliveries, over 250,000 total anesthetics, total regional anesthetics, again, over 250,000 because we didn't do many general anesthetics, total vaginal deliveries. There was a C-section rate of 31%, so fairly normal for the what we understand about the overall practice in the country at the time, and a 70% C-section rate. But what I want to look at here specifically is their general anesthesia for C-section rate, and they had 5,000 general anesthetics in this series. The incidence of failed intubation in the series was 1 in 533. Now I asked Dr. D'Angelo, what did that mean? How did you define failed intubation? And he admitted that they really did not define that term. He noted that it was generally meant that the first attempted DL was unsuccessful and an other option was necessary. So the incidence of failed intubation is considerably lower and is often quoted in textbooks, but there were no maternal deaths due to failed intubation or failed ventilation in that series of 300,000 patients. So failed intubation is not a death sentence. And in fact, it doesn't even seem to be a significant source of morbidity in this population. In addition to better training, we have a wide variety of airway management tools that we did not have 20 years ago. We all are familiar with the difficult airway algorithm, and we've been trained in how to manage difficult airways. We have devices such as the LMA, the ProSeal LMA, the Intubating Lma, and the glide scope. Let's look at these a little more closely. So you might say, LMAs for C-section, really? Is this guy serious? Well, yeah, back in 2001, Hahn and colleagues in the Canadian Journal published a review or a series of over 1,000 elective cesarean sections performed under general anesthesia. All these patients have been MPO for 6 hours, treated with ranitidine, sodium citrate, and all had successful general anesthesia. Only 7 of that over 1,000 patients required intubation. And this was not because of some serious problem. This is because they couldn't get the LMA to seat right. We've all had those patients where it doesn't want to sit right, it slips, it slides, you're not comfortable with the ventilation, so the heck with it, let's just intubate the patient. No cases of aspiration, no hypoxia, no regurgitation, no laryngospasm. So we may have become overly cautious over these last 30 years, and we may just be practicing defensively. Failed intubation at C-section, what are your options? Well, the ProSeal LMA early on was reported to be a valuable tool for a rescue device. The real difference between a ProSeal LMA and a standard LMA is, one, it's not disposable. Two, it has this secondary channel for venting the stomach or passing an NG tube if you so desire. And it's purported to be able to handle a higher seal pressure than the standard LMA, which supposedly isolates the trachea better from the esophagus. I can't swear to that. We have the Intubating Lma. Many of you have seen these if you haven't used them. It's designed to allow intubation of the patient at the same time that you attempt to place an endotracheal tube in these patients. It can be a very valuable tool. However, the confidential inquiries that I just cited, it's pertinent to note that the single death in that series from failure to ventilate was a patient who was actually being ventilated with an intubating LMA, but the practitioners continued to try to place an endotracheal tube and eventually lost control of her airway with their continued efforts. McClure noted that the anesthetist must avoid the natural behavioral patterns of fixation and denial, where tracheal intubation is seen as the goal rather than oxygenation of the lungs. So you need to avoid getting carried away. Let's talk about the glide scope. These have become fairly ubiquitous in operating rooms, and hopefully most of your obstetric anesthesia operating suites. These have, I think it's safe to say, revolutionized laryngoscopy for many of us. I went to take this picture, and I only intended to take a picture of the resident placing the scope into the patient's mouth, but inadvertently got a great view of the cords there on the screen in the background. These things make laryngoscopy and intubation so easy, even internists and ED docs can do it. So, recent reports indicate this can be a very valuable rescue device in the obstetric anesthesia population. Turkstra reported failed intubation after a rapid sequence induction in a morbidly obese patient who, surprise, her epidural catheter had become dislodged on the trip to the operating room. And they noted that grade 3 and 4 views on direct laryngoscopy can easily be converted to grade 1 and 2 views with the glide scoop. But don't forget, we have vastly improved monitoring capabilities. Back in 1980, you did not have pulse oximetry in every operating room. You're lucky if you had pulse oximetry in your hospital. I trained in a major teaching facility on the East Coast, over 1,000 beds. There was a single pulse oximeter in the operating rooms even in the late 1980s. And that was not for clinical use, no, that was only for research studies. So we now have these everywhere, and they've pretty much revolutionized our delivery of general anesthesia, regional anesthesia, any anesthesia. But don't forget capnography. Again, capnography is a relatively recent addition to our armamentarium. Now, you know within seconds whether you are adequately ventilating, whether you've placed an endotracheal tube in the correct hole. You don't have to wait till the patient turns blue anymore. It's really, these two devices, it's hard to understate how much they have revolutionized our approach to airway management. But regional anesthesia is not without complications either. Again, from the SOAP SCORE project, quite a few serious, many permanent, and many potentially fatal complications of regional anesthesia. But the other side of not doing much general anesthesia is that it's probably keeping us from doing more general anesthesia, because we may not be getting enough practice at doing general anesthesia. And Charlie Gibbs recognized this way back in the 1990s, and he noted in one of his talks that perhaps the most worrisome aspect of the decline in use of general anesthesia for C-section is its effect on resident experience. Jenkins in the early 2000s reported that in the UK there was an increased probability that a trainee's first general anesthesia for C-section was likely to be during an emergency, not the time you want to be practicing a new technique. And our colleagues from Stanford, who you'll hear from later in this meeting, noted in 2005 that the declining rate of general anesthesia for cesarean section raises patient safety concerns. So, in summary, while it's our instinct to avoid general anesthesia in obstetrics, we should not be hesitant to employ it. Actually, we should embrace it because we're better trained, we're better prepared, we have better equipment and strategies, and you can argue that a non-urgent elective case is a good time to hone the skills that are going to be needed later in more critical situations. Thank you.